Good afternoon, everyone. Let me first thank the Organization of Pharmaceutical Producers of India for giving us this slot for speaking about digital transformation in healthcare delivery and healthcare services in India. So today I am going to talk about a mission which is called Ayushman Bharat Digital Mission. It's one of the 4 pillars of Ayushman Bharat. Ayushman Bharat stands on 4 pillars of Ayushman Bharat Digital Mission, which is the national digital mission of transforming how healthcare delivery or how healthcare services are delivered in India. Another pillar is Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, which is the largest insurance scheme on the world. Then we have Ayushman Bharat Health Infrastructure Mission, which caters to building up of infrastructure which is required for digital transformation. Then we have Ayushman Bharat Health and Wellness Centers, so that primary healthcare is also taken into account while the insurance schemes tackles the secondary and tertiary level. So let me only talk about Ayushman Bharat Digital Mission. It was earlier known as National Digital Mission, National Digital Health Mission. And as an intro, we all have now changed how we interact with our banks, with our vendors, with ourselves, with socially. We use digital technologies now more or less in every aspect of our life. And we think that, but how we interact with the healthcare is going to change very, very soon. And some of the initial steps, basic foundations have already been laid by this Ayushman Bharat implementation. You will see that in the small presentation that I have made, that various successes have already been happening in the digital mission, and how and what are the priorities of the government for the coming future. And it is inevitable that we are going to change the landscape of how healthcare delivery is happening. Next slide. I have it. So this is the vision. We want to support the universal health coverage, but in this support we are going to make use of digital technologies, we are going to make use of standards, we are going to make use of information which can travel from one location to another location on the consent of the patient, while also we secure the security and confidentiality of the data. If I want you to remember what OPPI is, I want you to remember only one thing: interoperability. I'll see that how interoperable we are going to make the services, the information, the claims, etc. All things we want to make them interoperable. So ABDM is a connector which is going to connect various stakeholders of our healthcare system. ABDM aims to build up this ecosystem. We are not going to make a single software, we are not going to make a single solution. We are here to build up an ecosystem which has huge participation from private players. So various healthcare ecosystem, whether they are government companies, government hospitals, private hospitals, practitioners, frontline workers, laboratories, etc., they can all interconnect with themselves if they all interconnect to ABDM. How they interconnect to ABDM? ABDM is laying out standards and some protocols which every solution or every digital solution can comply and therefore become interoperable. So if we achieve this interoperability, this is how on a smartphone of a health individual she can see that she has been a beneficiary of RCH, she has been a beneficiary of IDSP program, she has been to Ayush hospital, or she has taken a COVID vaccination, or she has gone to a private hospital also. All these records which are digitally made by different healthcare stakeholders would be made available to the individual on her own mobile phone. Earlier, in the current situation, we have different silos where information is kept, whether it is a government program or a private health hospital. Now with a unique identifier, we are calling it as Ayushman Bharat Health Account, which can be linked to a bank account where you link your financial records, health account where you can link your digital health records also. And this longitudinal health record can then be used by doctors, frontline workers, everywhere whenever the patient goes next to. So I was talking about ABHA. Let me also talk about various unique identifiers we are placing on each healthcare functionary. So patients will be identified by ABHA. These are unique identifiers which are more or less based on Aadhaar. We have 99% of our ABHA which are more than 48 crores in India now. more than 99% of them are based on Aadhaar, and therefore every individual can authenticate themselves either through biometric or through face authentication or through their OTP authentication that they are the same person who they claim to be. Then the healthcare professionals are going to be uniquely identified by healthcare professional registry, which is a digital registry where we uniquely identify that this is the professional, he or she has this kind of qualification, which is certified to be by the medical councils or the nursing councils. Then we have health facility registry. Health facility registry would also be unique identifier of the health facilities, including the laboratories, blood banks, hospitals, with geolocation, with the kind of services that they offer, and they would be then placed to usage of any person. So in future maybe Google would be able to show our health facility registry that these are the health facility registry around you. So currently also Google shows that, but that data is not backed by government, it is not certified by government, it is not verified by district. This data that we are building up is going to be certified and verified by, and this is all digital. This is completely paperless. Only an application has to be filled and verified by the district. Then we are coming up with a drug registry where the manufacturers, I know many of them are here, right from the manufacturing to the distribution to the end point, we are going to track the drug which is being manufactured right to the point of its usage. The drug registry is under preparation. This is the statistics, this is not future I am talking about, this is already that we have done, only that we are going to make it adopt more and more. We have already 48 crore Aabhas in the country. We have more than 2 lakh health facilities and professionals already registered with us. Various indicators I was talking about, various stakeholders integrate with us and then integrate with everybody, and therefore they create interoperable health records and their softwares are able to talk to everybody. The patient is able to see all the records which she has created in every different locations. We have 154 of them already integrated with us, but around more than 1800 are on our sandbox where they are trying this integration process. More than 32 crore digital health records are now accessible to the people who have created their Aadhaar on their own mobile phones, whether it was created in a PHC, whether it was created in a tertiary hospital, or it was created in a government program, or it was created in a private hospital. All these records are now accessible to people on their own mobile phones. Then I leave the health token. You might have seen various government hospitals. You can digitally register yourself through the scanning of a QR code. So this is a complex slide. I'm on the technology stack, but I'll break it down into 3 more slides. These are 3 verticals. These 3 verticals are the exchanges or the, I'll say, interfaces where different information or claims or services can travel with interoperability. In unified health interface, suppose I want to buy anything from Amazon, I need to go on Amazon platform, and my seller also has to be on Amazon. So it's a platform. I can't buy from a seller if the seller is only on Flipkart if I want Amazon. But as opposed to the platform-centric approach, if we go to an interface approach, I can put my query to an interface, and the interface can throw that query to various other players who are trying to supply it. So in unified health interface, suppose I put in a request that I want to do consultation from a doctor who is a gastroenterologist and can speak English, who is around 500 meters away from my home. And from the platform I am putting this query, maybe my doctor is not using that same platform, so he will not be able to I will not be able to see him. But if I put in this query on an interface, this query could be sent to various other platforms, and those platforms any doctor can respond to. For example, I can put my query on Tracto, and a doctor on eSanjeevani can respond to my query. So this is how not only discovery of services but also availing these services, teleconsultation can also happen through unified health. I can also pay for those services through interoperability. Next is another exchange is health information exchange. As I was telling in my first slide, that various data which was created by various other stakeholders or various solutions will become interoperable. This is how it is going to happen. A health information provider could be one person, suppose it can be a government program, and I, as my mobile phone application could be health information user, and that user can access that information if both the user platform or the phone application and the government program are following same standards. I can email from my Yahoo email to your Gmail account because both of them are following the SMTP protocol. So if I have already laid down the protocols and standards, if these two software also follow the same standards and protocol, my information can be travel from that software to my own application. And similarly, these entities can change as health information user or health information provider. Different entities can talk to each other. The information can be accessed from one location to another location. Only that it has to pass through a gateway which will be having a consent manager. The patient has to say yes whenever information has to travel from one location to another location, and therefore looking at the sensitivity of the medical data, it can only travel once we have a collected or granulated information or consent from it. Then with the help of insurance regulator, we are building up this national health claims exchange where medical data or discharge summaries can be put on to this single platform where various insurance payers can use that platform and can adjudicate those claims quickly. It is said that in processing a single claim we spend around 500 to 600 rupees, and therefore OPDs are not covered in India in most of the insurance companies. But if we have this manual, if we replace this manual adjudication to programs to say machine learning or digital claims, then it can happen that we are able to increase the insurance coverage. So this is how we make interoperable claims also interoperable, services also interoperable, information also interoperable. Through Aishman Bharat Digital Mission, we identify different stakeholders. We ask them to follow the same standards and protocol and make their services interoperable. So this is the end of my Aishman Bharat Digital Mission. This is how we think that in the very near future, this healthcare delivery is going to have a revolutionary change. Aadhaar was conceptualized in maybe 2014 or 9, but then it was really adopted in 2019. UPI was conceptualized in 16, it was really adopted in 19. We are only 2 years old now, and we are at the scale of adoption. So if you have met me in last September 2022, my records were only few hundreds. But in this September or November 2023, I am standing on 32 crore digital health records. So we are having this. Thank you so much for this opportunity, and let us know if you have any other clarifications to ask. Thank you so much.
Thank you so much, Dr. Akshay. Like he mentioned, NHA team is here to create or assist you with the creation of Ayushman Bharat health accounts in case you want it. I'd here like to invite Mr. Sudhindra Kulkarni, Managing Director and CEO South Asia at ASEAN Ferring Pharmaceuticals, to please join us and give a small token of our gratitude to Dr. Akshay Jain.